Hello and welcome everyone again. So in this section, we will be talking about the screening guidelines. Toronto Notes offers guidelines for 6 diseases: breast cancer screening guidelines and lung cancer screening guidelines, colorectal cancer screening guidelines, as well as cervical cancer screening guidelines. And the last one will be prostate cancer screening guidelines. I will be talking about all these diseases. I have a brief summary for all this. It's high yield. I assure you that you will be having at least maybe 5 questions from these guidelines. This is not the only guidelines that will be laid out in your exam. You can find the other one in the site. I have also another summary for the rest of the guidelines. If you feel that you will be benefit from that, kindly write for me in the comment below, and don't forget to subscribe for the channel and to activate the notification button. And of course, if you like the video, you can press on like button. Okay, so let's get going. First, I will be showing the algorithm for the guidelines regarding the breast cancer screening. So breast cancer screening, when you face the question stem, it will be showing details about the patient. If the patient doesn't have any cancer breast history or in her family, and if the patient does not carry a BRCA1 or BRCA2 gene, and the patient has no history of radiotherapy before she turned to 30 years, or less than 80 years before her presentation to the clinic, you would follow this scheme. So you will start screening her at age 50. That's the cutoff age. You will do mammogram. That's very important, every 2 to 3 years, up to age 74. Okay, so less than age 50, there is no screening for that if the patient has none of the above mentioned 3 points: cancer, breast history, BRCA1, BRCA2 gene in first degree relatives, and no history of chest radiotherapy. So what about other modalities of screen tools? MRI, no tomosynthesis, no ultrasonography, and no clinical breast exam or self-exam for screening. This is also high yield, no clinical breast self-exam for screening. Very simply laid out. And last point to be remembered, that you may choose not to screen. So if the patient is around age of 50 and above, and you found out that she has some harmful effects from screening her with the mammogram. For example, she had a thyroid benign neoplasm, or she had any issue regarding her lung fibrosis, for example, that will be aggravated by the radiation, then you might not to screen her with a mammogram to avoid harm. Okay, so let's get back to the Toronto Notes and see what is written there. So the guidelines came out in 2018. It shows that average risk women, we mean by average risk women that the patient does not exhibit either of the 3 points that we said. The patient has no personal history of breast cancer. The patient has no history of breast cancer in first degree relatives. Patient is not has a mutation in her BRCA1, BRCA2 genes, and there is no previous exposure to chest wall for radiation. So this patient considered average risk woman, and the patient age from 40 to 74. So what we will do is the same as before we said in the algorithm. We will not screen if she is less than 50, recommend not screening with mammogram. And if she turned 50 years old, we will recommend screening every 2 to 3 years. And above 75, The screening will be if the benefits will be recommended if the benefits outweigh the harm. So that will be depending on your clinical judgment. As we said before, MRI and ultrasound is not recommended. Clinical breast examination is not recommended to be performed. Breast self-examination, they recommended against routine breast self-examination, as we mentioned before. All right, so let's move on to the next one, which is lung cancer screening guidelines. I also will be going to show you the algorithm for lung cancer screening guidelines. So this is the lung cancer screening guidelines algorithm. So when the patient has no history of lung cancer and he turned 55, his age is 55 up to 74, we will be inquiring about smoking history. If the patient is smoking currently, or he had smoked, or he or she had smoked within the last 15 years before he turned 55, and he quit before 15 years, so he maybe, let's say for example, he quit smoking 10 years ago, we will be asking how many pack of cigarettes he smoked every year. If he had smoked more than 30 pack, so the magic number here is 30 pack per year, then we will screen him with low dose CT scan every year for 3 consecutive years. Okay? Anything else, we will not screen for the lung cancer. I will get that again. The magic numbers here is 55 years old, 30 pack of cigarette a year, less than 15 years quit. So if the patient is currently smoking, you will just check on how many pack per year he smoked. If the patient quit more than 15 years, no screening is recommended. If the patient smoked less than 30 pack per year, no screening is recommended. If the patient is less than 55 years and he doesn't smoke, or he haven't smoked any, no screening with anything. Okay, let's see what the Toronto notes says about that. So 2016, Canadian Task Force Preventive Care Healthcare said that apply to adults aged 18 and older who are not suspected of having lung cancer. They put age 18, but they recommended a CT scan for annual screening aged 55. So this is the magic number, with at least a 30 pack per year. This is the second magic number, who currently smoke. So he is currently smoking or quit less than 15 years ago. We will do that annually up to 3 consecutive years. Very clear, very straightforward. Just X-ray is not recommended to screen for lung cancer, either with or without sputum cytology. All right, let's move on to the colorectal cancer screening guidelines. It's look a bit confusing here, so I will get to my algorithm in order to simplify everything for you guys. So colorectal cancer. If the patient has none of the following, no history of colorectal cancer in the patient himself or herself, and or in his family, and he has no history of polyp, no history of inflammatory bowel disease, particularly ulcerative colitis, and patient doesn't have a known history of having a familial adenomatosis polyposis gene or HNPCC gene. So the patient doesn't have any of these, then we will proceed with the algorithm. If the patient has any of these items, we will check on the Toronto notes. It shows some details regarding every one of them. Okay, so let's see. If the patient turned to 50 years, so his age is 50 up to 74, we will screen him. So the cutoff age is 50 for colorectal cancer up to 74. We will screen him with fecal occult blood test, okay, every 2 years. So every 2 years, fecal occult blood, FOBT or FIT, or flexible sigmoidoscopy every 10 years. So we'll do it once every 10 years. This is for both of these tests is applied for any patient who turned 50 years up to 74. And the recommendation is much stronger for the patients above 60 years. Okay. Colonoscopy is not indicated as a screening test, but for these type of patients who doesn't have none of this, because we will see that colonoscopy sometimes is used in patients who exhibit these genes. But as a rule of thumb, patient who does not have any of the following criteria, does not meet any, who does not meet any of this criteria, we will just screen him with fecal occult blood or flexible sigmoidoscopy, 2 years for fecal occult blood testing, and flexible sigmoidoscopy for every 10 years. Okay, let's check on the Toronto notes to see what's written in there. So the guidelines came in 2016. It applied to average risk individuals, asymptomatic, and has no family history of ulcerative colitis, polyps, or colorectal cancer. This is considered average risk individuals. These average risk individuals should be started screening at age 50. We mentioned this before, and the identification of risk factor should begin earlier before age 50, inquiring about the family history, okay, and the history of genes, the history of cancer. They recommended screening with fecal occult blood testing, either fecal occult blood testing or FIT or FOBT every 2 years, or flexible sigmoidoscopy every 10 years. So it's the same that we mentioned, and colonoscopy is not recommended. Again here, screening is not recommended after age of 75, but it should be assessed on individual basis. For the scope of our test, MCCQE1 test, we just memorize that the patient, if he turned 50, we will start screening him every 2 years or every 10 years. Okay, so this algorithm will show if the patient has any positive finding on the criteria we mentioned. If the patient is symptomatic, diagnostic workup, straightforward. If the patient is asymptomatic, we will be checking but have a positive family history. We will be checking on the genes. If positive, we will counsel the patient, and we will do colonoscopy every 1 to 2 years at age 20 or 10 years before the earliest case in the family, whichever comes first. For example, if the patient's father has a colon cancer at age 35, we will begin at age 20 screening. If the father has a colon cancer at age 25, we will begin screening at age 15 for HNPCC. Okay, this is very specific and very high yield for HNPCC. But for the FAP gene mutations, we will do sigmoidoscopy every year, okay? And we will begin at age 10 to 12. For FAP, 10 to 12 years old, begin screening, okay? AAPC, we will do colonoscopy. Again, colonoscopy every year, beginning at age of 16 to 18 for AAPC gene mutation. Okay, let's move on to the other criteria. If there is first degree relative with cancer or polyps, adenomatous polyps, the patient who's diagnosed in the first degree relative is less than 60 years old, or has 2 or more first degree relative at any age, we will do colonoscopy every 5 years. So this is where you will do colonoscopy every 5 years. And the cutoff age for this type of patients is 40, or 10 years younger than the earliest case of polyp or cancer in the family, whichever comes first. So to simplify this one, if the first degree relative has a cancer at age, let's say 45, we will begin screening with colonoscopy at age of 35. Okay, so it's 10 years younger. Okay, and for the other criteria, one first degree relative with cancer or adenomatous polyps and his age more than 60, let's say more than 60, 65. Let's say the father at age of 70. Okay, we will begin screening at age 40 for the patient. Very high yield, comes in the exam frequently. 1 second, let's move forward. If the patient has 1 second degree relative, that's the cousin or the grandfather, grandmother, or the third degree relative affected, the average screening risk screening, that means we will do fecal occult blood testing or sigmoidoscopy, and it will begin at age 50. Okay, so the last thing, if you found a polyp on colonoscopy, what you will do, you will assess if this is a single or multiple polyps. If it's one polyp, is it less than 1 centimeter? Yes, you will do colonoscopy in 5 years. If this polyp is more than two adenomas, you will do colonoscopy every 3 years. Okay, so this is a brief and general overview for the screening for the colonoscopy according to the recent guidelines. I will be moving to the cervical cancer screening guidelines. I have an algorithm for this as well. It will make, I hope it will make it simpler for you guys to learn it. So cervical cancer, it has another criteria. We will check on if the patient has never sexually been never being sexually active. Patient has history, never had history of cancer. The patient had never had unclear abnormal test result. The patient cervix is present, and the patient doesn't take any immunosuppressant or in immunosuppressant state. So at this, if we checked on all this and we found them negative, then we will check on his age. The magic number here is 25. If the patient turns 25 years old and above up to 69, we will do pap smear every 3 years. Okay, very simple. 25 up to 69, we will do pap smear every 3 years. Okay, less than 25, no screening. More than 69, no screening if 3 consecutive screening is negative. Very simple. Okay, so let's see what's the Toronto notes laid out for this. So they are talking about the method of screening, either pap smear, conventional, or liquid-based cytology testing. So either this or this. Either it will mention pap smear on the options or in the test stem, question stem, or it will say liquid-based cytology testing. It's the same. Okay, the sampling endocervical and exocervical, it's aimed to sample the transitional zone. Okay, very important. They are sampling the transitional zone. Okay, and it identifies squamous cell abnormalities, right? Okay, it's less reliable for glandular abnormalities. So please just note that there is a high rate of false negatives for a single test. And this is justify the use of the test more than once in order to exclude false positive, false negative. So if it's high, it has a high false negative, that means that we are losing some positive results and it appears on the test as negative, so we repeat the test. Okay. Okay, cervical cancer screening guidelines is different by province, from province to province. We will see here that it's talking about Ontario guidelines. It's a little bit different from the general guidelines we mentioned. We will just see what is the age, cutoff age in Ontario. So in 2013, the Canadian Task Force for Preventive Care Guidelines recommended screening for all women more than 25 years, more or equal to 25 years old, every 3 years, who are or have ever been sexually active. Okay, and the conditions that goes under the sexually active status is intercourse or digital or oral activity with a partner of either sex. Okay, the age 25 to 29 has a weak recommendation, which we here is called conditional recommendation, but it has stronger recommendation for screening above age of 30 to 69. So you just memorize that the age is 25. We start screening with a pap smear every 3 years. Okay. All right. So the discontinuation should be after age of 70 if 3 normal tests in a row and no abnormal test in the last 10 years. So 3 tests in a row, it will be 9 years because we screen every 3 years. If it turn out to be negative, then we will stop testing at age 70. Excellent. So Ontario guidelines, they are recommending screening women more than or equal to 21 years old who are or have been sexually active. So this is the different status. If it's more than 21 years old or equal and have been sexually active, you will screen them. If the cytology is normal, you repeat that every 3 years. Okay? If the patient turns 70, you will consider 3 successive negative pap smear and you will discontinue, same as the general guidelines. Women who are not sexually active by age 21 should delay cervical cancer screening until sexually active. This is now different from the general guidelines. So they are considering if the patient is not sexually active, you just should delay the screening until the patient turned 25 years old. Pregnant women and women who have sex with women should just follow the routine cervical screening regime. It's the same for the pregnant women and the women who have sex with the same gender women. Okay, so let's move on. Women who had hysterectomy, we will be dividing that into either total hysterectomy or subtotal hysterectomy. The total hysterectomy, was it for a benign disease or was it for the malignant disease? If the patient did hysterectomy for a benign disease and no history of cervical dysplasia or HPV infection, we will continue to swab vaginal vault. We will discontinue screening. If the hysterectomy was for the malignancy, then we will do the screening for the vaginal vault. Let me repeat this again. If the patient did a total hysterectomy for benign disease, we will discontinue screening. If considering that the patient has no history of cervical dysplasia or HPV infection, okay? If it's a uterine malignancy, then you should continue on swapping the vaginal vault, right? The subtotal is the same. We will continue screening according to the guidelines. The exceptions to these guidelines is immunocompromised patient and previously unscreened patients. So this is exceptions to these guidelines in Ontario, okay? For more information, you could just check on the gynecology section. All right, so we reached to this algorithm, this very high yield. Usually they ask about ASCUS, which is abnormal squamous cells of unknown significance. They give you a patient who's like 35 years old, tested positive for human papilloma virus, and they ask you what you will do next. So you will choose colposcopy, right? They could also put the patient who has inadequate sample, and you will choose repeat cytology in 3 months. I'm just mentioning some examples. It's very high yield algorithm. I really recommend that going through this before you go to your test. Okay, let's move on to the last part of our section today, which is prostate cancer screening guidelines. Again, I have an algorithm for you guys to help you memorize it. It's very simple. The prostate cancer screening guidelines should not take you 2 seconds to solve it, okay? All right, so prostate cancer with no history of prostate cancer, okay? At any age, no screening with PSA. Full stop, that's it. So prostate cancer, you should inquire about history of prostate cancer before in the patient or in the family. So no history, so no PSA screening, okay? However, it's a weak recommendation for age 55 to 69. Okay, that's it for the prostate cancer. Let's see what the Toronto notes is mentioning. In 2014, Canadian Task Force for Preventive Care Guidelines recommended not using prostate-specific antigen for prostate cancer screening in any age group. Okay, with the strongest recommendation less than 55, as we mentioned, and conditional, which is recommendation, which means also weak recommendation from age 55 to 69. Okay, that's it. That's all about prostate cancer. Thank you very much for listening to this section of presentation. Last thing, I will just mention some other guidelines. There are other guidelines for other diseases. Please, if you felt that this presentation is helpful for you, as part to encourage me to continue on explaining all these guidelines, which is the most recent one, according to the Canadian Task Force for Preventive Care, just please write in the comments below, subscribe to the channel and activate the notification button. Thank you very much, and I hope the best of luck for you in your preparation for the test.